Hello, everyone, and thank you so much for taking the time to attend today's webinar. It's a pleasure to be here, and thank you, Sherry and Erin and everyone at Pearson for having me. I do have to disclose that as an author of the Vineland 3, I do receive royalties from Pearson, as well as from Wiley for some books that I have and that I consult on clinical trials that use the Vineland. You have your learning objectives here and in your handouts, and at any point, like Sherry said, if you have questions, they can be submitted to me if we don't have time to go over them. But I am hoping to leave ample time at the end of the presentation for questions. So we're talking about profiles of adaptive behavior in autism spectrum disorders. And before I get started, I just wanted to discuss something that's going on in the field right now as far as how we address individuals with autism or autistic individuals. So using person-first language versus identity-first language. And this is something that really is dependent upon the audience. And I have great respect for the individuals and families with whom I work. And I usually ask them what's their preference. And even though a lot of people may say, well, self-advocates say it's identity first, so autistic individuals, and professionals say person first, I've found personally that it really depends on the individual. So last week, an adult with autism was asked this while presenting to my class of students at Emory University. And he, very forthright, he said, I am an individual first, and autism does not define me. So he actually retains person-first language, despite many other self-advocates using identity first. So you'll probably hear me say them interchangeably, just because I don't know who I'm addressing here, that this is remote. So pardon me, and I certainly don't want to offend anyone. I want to give forth the utmost respect to everyone in the field. So with that, you are all, as clinicians, very familiar with the diagnostic criteria for autism. So in the DSM-5, there are two areas of Hallmark impairments. The first and foremost are the social communication impairments. And by definition, the individual has to meet criteria across all of these three social communication deficits. And that is also including the nonverbal communication, things like facial expressions, eye contact, gestures. And then we have the restricted and repetitive behaviors. So individuals have to have at least two of these, either currently or by history. These would be your motor mannerisms, flapping hands, posturing, jumping up and down, spinning, or your need for sameness, not liking transitions or changes in routine, the highly restricted fixated interests on a topic, these circumscribed interests that become all-consuming, where an individual collects facts on a topic and then wants to relay those facts to anyone in earshot ad nauseum. So it becomes very one-sided and in your face. And then there can be sensory sensitivities, either hyper or hypo sensory reactivity, seeking out certain senses, textures, things like that. So those are the symptoms of autism. And in the DSM, these symptoms must be present in early childhood. So even if they go undetected until adolescence or adulthood, which is often the case, certainly in individuals that have intact cognition and language, even the subtle symptomatology is usually there and present in the first few years of life. And then these symptoms need to cause clinically significant impairment across areas of functioning in life. And usually these are adaptive deficits, so we'll talk about that. And obviously the disturbances are not better explained by another disability. So when we diagnose autism, we give clinical specifiers to that diagnosis. So I will say this person meets criteria for autism spectrum disorder, but then I am also going to describe what that profile looks like. There is cognitive delay or developmental delay. There is speech delay. There is a known genetic mutation like 3q29 deletion syndrome, or there's an associated neurodevelopmental disorder like ADHD. So in addition to listing those specifiers, if the individual also meets criteria for example, for a specific communication disorder, for a specific genetic disorder, and or for ADHD, I will give additional diagnostic codes for those co-occurring conditions, in addition to the clinical specifiers. So the severity levels in the DSM, they have them for autism spectrum disorder as well as for intellectual disability. And in both cases, they are keyed into level of independence, or on the flip side of that, how much need for support does this individual. Level 1 would be the least amount of support, all the way to level 3 requiring very substantial support. So again, severity levels are keyed into adaptive behavior because adaptive behavior is independence. So just to give you an overview of where we are in the field of autism, in the general population, the prevalence rates are 1 in 54. It's 4 times more prevalent in boys than girls. And in females, the presentation can often be quite complex and potentially different than it presents in males. And the average age of diagnosis in our country here in the US is 4 to 5 years of age. However, we can reliably diagnose autism by 18 to 24 months when we are conducting comprehensive diagnostic assessments. So there is a 2 to 3 year gap between when we can diagnose autism and when we are diagnosing autism. And that's in best case scenarios. Certainly for disadvantaged communities, for racial and ethnic minorities, these mean ages of detection go higher and higher if these individuals are ever ascertained at all or correctly ascertained. And then right now, co-occurring intellectual disability is about 1/3 of the autism spectrum. So the vast majority of autistic individuals will actually have intact cognition, meaning they have the cognitive capacity to academically be in their mainstream classes, to be independent as adults, but we'll talk about whether or not that's the case in a little bit. And we know autism is one of the most, if not the most, heritable of neurodevelopmental disorders. And so if a family has one child on the autism spectrum, the likelihood of having a subsequent child is 1 in 5. So that's a 20-fold increase. Another 1 in 5 biological siblings will show shadow symptoms of autism, meaning that they will have some symptoms, but not enough to meet full criteria for autism. And then another 1 in 10 biological siblings will have non-autism developmental delays. This would be like a language delay, speech delay, or developmental delay. And so about 50% of siblings are going to be vulnerable in their development and require intervention to some degree. When we talk about the spectrum, people use terms like low functioning, high functioning, and everything in between. When people start using terminology like this, it's usually keyed into the level of cognitive functioning of the individual. So historically, low functioning autism has been autism with cognitive impairment and or minimally to nonverbal individuals, whereas quote unquote high functioning autism was autism without intellectual disability. So Asperger syndrome, for example, by diagnostic criteria had no cognitive impairment. When you have cognitive impairment, you're more likely to have co-occurring medical conditions like seizures, genetic disorders, cardiac defects, metabolic issues. Whereas on the flip side, when you have intact cognition and language, you may, and in some cases, have more insight into your disability, into the struggles that you're having. And with this comes an increased likelihood for co-occurring psychiatric comorbidities like anxiety, depression, and suicidality. So these are things that we're always going to be thinking about, whether it's a diagnostic differential and or co-occurring condition when we're doing a diagnostic evaluation. So a comprehensive evaluation for autism in this day and age, what's considered gold standard or best practice, would be conducting a screener to see if the child needs a comprehensive evaluation, then an assessment of developmental or cognitive profile, profile of speech, language, and communication, the profile of diagnostic criteria, so the social communication, interaction, and play skills, and then this restricted and repetitive behaviors. But then assessment of adaptive behavior. This is now standard practice to conduct a measure of adaptive behavior, whatever measure you're choosing, as part of the diagnostic evaluation. So first and foremost, when we're assessing and defining intellectual disability, we want to make sure that cognition and adaptive functioning is intact. So we're giving standardized assessments for both of those. The DSM-5 currently stipulates that criteria for ID consists of delays in both cognition and adaptive functioning that's approximately 2 standard deviations below the mean, which is usually 100 on standardized assessments. And specifically for adaptive functioning, the areas of delay are in communication, daily living, socialization, and independent living. So note here that adaptive motor skills are actually not listed as deficits for adaptive behavior in the DSM-5. And then for ID, there have always been severity levels, mild, moderate, severe, and profound. But historically, these have been keyed into the IQ number or level of the individual. Whereas now with the DSM-5, they are keyed into level of supports needed or level of adaptive functioning. So that's a paradigm shift in our field. So I encourage all of you to get a hold of this article by Tassé that really breaks down the behavioral indicators for what these benchmarks for severity are across the lifespan. So you see here there's early childhood, childhood and adolescence, and adulthood, and then it will go through all the severity levels and give you benchmarks for behaviors. So if we think of cognition as an individual's repertoire of skills or their optimal capacity, because when we're assessing for cognition, we're doing it under optimal conditions. We want the best performance from the individual to truly understand what all the skills are that are included in their repertoire. Think of that as what individuals are capable of doing or what they can do. Adaptive behavior, on the other hand, is quite different. It is how a person applies the behavior that they have in their repertoire of skills when life demands the behavior. And it's how they do this with complete independence. That means without any supports, help, prompts, or reminders from another person. So it's self-sufficiency. So it's not just what a person can do, it's what they actually do with independence. So you can have deficits in adaptive behavior because you have the skill, but you don't know how to apply it in real life. Or you could have deficits in adaptive behavior because you actually don't even have the skill yet. So the skill first needs to be taught and then taught how to be applied in the real world with independence. So there are characteristics of adaptive behavior that include being age-related. That means that at different developmental stages, there are a different repertoire of adaptive skills expected. So young toddlers have different repertoires of skills than adolescents and adults. And adaptive skills are defined by the expectations and standards of others. And we'll talk about this and the importance of using third-party informants. It's defined by typical performance, not ability. That's the does do, not the can do. And distinct from cognition or IQ, which is relatively stable over time, adaptive behavior is quite modifiable. It can change over time and it can change quite quickly. And that's why measures of adaptive behavior are used more increasingly as outcome measures in clinical trials and treatment trials. You can change adaptive behavior by teaching a skill. So through intervention, you can change adaptive behavior by lack of intervention. And all sorts of environmental factors can change or modify adaptive behavior. And unlike many other things in life where people just strive to achieve and be overachievers and above average, above the norm, in adaptive behavior, you want an individual to be solidly average. So adequate is the appropriate goal. You don't want to excel in adaptive behavior. And that's because you don't want a young child, for example, roaming the streets of a city by themselves, taking public transportation, going out and conducting grocery shopping and driving a car. So you just want things to be at age level. So Edgar Dahl in the early 1900s was the first to develop a measure of adaptive behavior, and it was called the Vineland Social Maturity Scale. And at the time, he was focusing on the importance of a construct called social maturity or social competence. And when he developed this measure, which looks very much like the Vineland Adaptive Behavior Scales today that Sarah Sparrow expanded on, he was working with significantly and severely intellectually disabled individuals. So he was saying that it's very hard to assess for adaptive behavior in a clinical setting when you can't see the broad range of these real life skills, but it's also hard to ask the individual themselves about their adaptive skills because they might have impaired insight and awareness into those deficits. So he really felt that the assessment of these constructs had to be conducted with a third-party informant, and that this was best conducted through a semi-structured interview so that you gather information about the entire lifestyle and out in the community and different contexts with different people, and that's how you assess. So when Sarah Sparrow, Dom Cicchetti, and others created the expansion of the Vineland Social Maturity Scale in the 1970s, which became the Vineland Adaptive Behavior Scales, they stayed true to this semi-structured interview. So the original Vineland that was published in 1984 was solely a semi-structured interview and not a rating scale. So I had the pleasure of working with Sarah Sparrow and Dom Cicchetti when I arrived at the Yale Child Study Center for my postdoctoral fellowship. And I was mentored by Ami Klin, who specializes in autism. And Sarah and Dom were close colleagues of Ami Klin's. And so I naturally was able to work with them. And I just developed a passion for this concept of adaptive behavior. And I would go on to publish some research that I'll talk about in a minute with them. And sadly, in 2010, Sarah Sparrow passed away and bequeathed the authorship of the Vineland to me because at that time, Pearson was just starting the revision of the third edition. Sadly, her husband, Dom Cicchetti, the biostatistician of the Vineland, he passed away in 2019. So now I have the honor and the privilege, but also the very significant responsibility for carrying on the legacy for both of them with authorship of the Vineland. And so the Vineland 3, for those of you who are less familiar with it, it is structured in this way. There are 4 core domains of adaptive functioning. Within them, there are subdomains. So within communication, there's receptive, expressive, and written. Within daily living, there's personal care, domestic care, and community living skills. Within socialization, there's interpersonal relationships, play and leisure skills, and coping or emotional regulation skills. And then optional is the motor domain for fine and gross motor. This is optional now in the third edition because, like I said, the DSM-5 criteria for intellectual disability no longer stipulates that motor impairments are part of that criteria. There's also a maladaptive behavior index that's a screener for challenging behaviors that get in the way of adaptive functioning. So you can find out much more information on the Vineland 3 on Pearson Assessments website, but there are 3 forms. The gold standard interview form. Then there is an option to give a parent rating scale, parent or caregiver rating scale, if you cannot do the semi-structured interview. And then there's also a teacher form, and that is in the form of a rating scale. Each of these 3 forms has a comprehensive version and a briefer called domain level version. It's called the domain level because it only has those broad domains. It does not have the 11 subdomains. And then all 3 forms are available in paper form or online through Q Global. And they all go from birth to 90, with the exception of the teacher form that is ages 3 to 21. So the majority of research in the field of autism that's been done on adaptive behavior has been conducted using the Vineland because it is the gold standard measure worldwide. And historically, the research showed that there are delays in adaptive behavior in autism, and the adaptive skills were found to fall significantly below both age and IQ expectations. However, more recently, we are finding that because the spectrum of autism has become so broad, and actually there are now much more individuals on the spectrum that have intact cognition and language, that these adaptive profiles differ depending on the level of cognition of the individual. So in low IQ individuals, their adaptive skills tend to be on par, or if not higher than their mental age by cognition. Whereas in individuals with intact cognition and language, they're the ones with these significant gaps, with their adaptive skills falling substantially lower, especially in the area of socialization skills, which is not surprising given that it's a social disability. And of concern, this gap between cognition and adaptive functioning appears to widen with age. So this is research that I did with Dr. Sparrow and Cicchetti and Amiklin, where we originally looked at a small sample of 84 males at Yale, and they had intact cognition. Their average IQ was 100. So if you look here at the dotted line, that's their average IQ score. And then you can see the substantial gaps in their adaptive communication in red, socialization in green, daily living in blue, and the overall composite in pink. We were so struck by how significant this gap was. Look, in socialization, it's more than 3 standard deviations below IQ, that we analyzed another sample of individuals at the University of Michigan that Kathy Lord, where she was at the time, and we found the same patterns. So not only did they fall below cognition, but if we split the sample by age, the gap was wider in the older individuals versus the younger individuals. So with that, we wanted to look at that more closely in a much larger sample, which we did with the Simon Simplex collection of over 3,000 individuals, ages 4 to 16. And if you look on the far left here, the full scale IQ, we split the sample. The blue bar is the youngest ages, 4 to 8, and the green bar are the older ages, 9 to 16. Their IQs were no different from one another. So the older individuals had the same intact cognition as the younger individuals. But now if you look over here to the right, across all adaptive domains, the older individuals in the green had lower adaptive skills despite having the same cognition as the younger individuals. And so this gap did appear to be higher in the older kids. But that's a cohort sample. We wanted to look at this longitudinally. So at Yale, we did a study where it was early detection at age 2 with a follow-up confirmatory evaluation at age 4. And then we got a grant to follow those individuals again at age 8. If you first look at the dotted red line, this would be an equivalent of cognition that we derived from a developmental quotient at age 2. All the way up to age 8. This is showing the children at age 8 who had intact cognition, meaning no cognitive delays. And you can see that their average IQ is right at 100. But you can see over time, their adaptive skills are not keeping pace with their chronological development, nor their cognitive development. So that gap is significantly widening between cognition and adaptive functioning between ages 2 and 8. If we look at this same trajectory in the children at age 8 who had cognitive impairment, then you see that their mental age here with the red dotted line is much lower than their adaptive functioning. Now, this was not a treatment study, so we can only speculate here, but treatment could potentially have an impact here, that when we identify individuals with significant cognitive impairment, many of us as clinicians, and think of this yourself in your own practice, you are very likely, or more likely, I should say, to make a recommendation for adaptive skills intervention, meaning this person has very low IQ, teach them how to dress themselves, teach them how to toilet train, teach them how to count money, to go shopping, teach them how to take public transportation. We naturally make these recommendations, but we fail to do that as intensely, or if at all, in individuals who have intact cognition and language, because usually they're academically doing fine. So perhaps we're assuming that they have these skills when they don't. So just very quickly, Jessie Bradshaw, who was a trainee with us at Yale and then at Emory, who's now a professor at the University of South Carolina, she did a study on infants who were high risk, meaning they were the younger siblings of someone with autism, and we followed them from birth. And we did these developmental and adaptive assessments and diagnostic assessments at 12 months, 24 months, and 36 months, with the confirmatory diagnosis of autism at 36 months. You can see in this orange line that the children who were deemed typically developing in their nonverbal visual reception scores, this was using the Mullen scales. These are age equivalents, and that's why you see it increase over time. They were actually above average compared to the mean. Their adaptive socialization skills were solidly average, but lower. But this is expected because remember I said you don't want above average adaptive skills. We had highly trained research staff conducting the interviews, and these children, despite having above average cognition, had completely adequate adaptive skills. So that gap is parallel. The children who went on to develop autism at age 3 also had above average nonverbal functioning, yet their socialization scores on the Vineland trailed off. So that gap, even though they're acquiring new skills, they're not acquiring at the same pace as their cognition or age. So that gap widens between 12 and 36 months. This is showing us that this gap is beginning even prior to diagnosis. So it's emphasizing the importance of assessing adaptive behavior over time and early. And now if we go from infants to adulthood, the adult research on adult outcome is quite grim right now, unfortunately. When you look at the percentage of individuals who have intact cognition and language, meaning they should be able to be independent adults, they should live independently, hold down jobs, have successful relationships, only 24% of them meet that criteria. And even more sobering, you follow those up 20 years later, that percentage of the pie decreases. So we really have a long way to go in fostering better outcomes for our adults on the spectrum. And historically, the best predictors of good outcome in adulthood have been IQ and language. And yes, these two things are important, but what more recent research is finding, like why are these individuals that do have intact cognition and language still failing to have good outcome? It's because people were not focusing on adaptive behavior. And this is one of my favorite articles that came out of Australia a few years ago that really brings to light the misnomer of this term high functioning autism, because there really is not much that's high functioning, quote unquote, about the vast majority of adults that are failing to achieve independence despite their average to superior IQ and their strong verbosity. So we need to, as a field, shift away from using this terminology of level of functioning in that regard. There is a body of research from Debbie Fine and her colleagues. Debbie Fine was my mentor in graduate school at the University of Connecticut. For those of you who are familiar with the modified checklist for autism in toddlers, or the MCHAT, it's a screener used by many pediatricians worldwide to screen for autism, and it was developed by Debbie Fine, Marianne Barton, Diana Robbins, and colleagues. And what happened with the MCHAT research was that they were doing all these early detection studies of diagnosing these toddlers, but then following them up at periodic time points throughout their childhood to confirm the diagnosis and look at the trajectory of how accurate the MCHAT was. And so the same team of expert clinicians, you can't get better than these clinicians, we're following these children up at school age and saying, we were the ones who gave the diagnosis of autism at age 2, and we are no longer seeing the symptoms required for retaining the diagnosis at age, whatever it was, 8 or 9. And so this happened in less than or about 10% of their sample, and they called it optimal outcome. They did not use the word cure. They just said these were previously diagnosed individuals on the autism spectrum who no longer meet criteria for autism. If you look at that 10% of the sample, the entire sample of optimal outcome individuals had intact language, intact cognition, and adequate adaptive functioning. So just to go over very briefly how to administer an adaptive assessment using the Vineland 3. Right now, the best and easiest way, in my view, to do it is the computerized version on Q Global. You can conduct it on a computer or tablet, something like an iPad, and you don't have to worry as the clinician for obtaining basals and ceilings and all of that, because the computer program is doing all of those algorithms for you. Not to mention that the items come up by topic area, whereas if you're giving the paper form, you have to know where all the items are by topic area. So for example, if I want to ask within the socialization domain, in the subdomain of interpersonal relationships, I want to ask about the topic of friendships. I ask the parent or caregiver a broad question, tell me about Stella's friendships. And with the information that the parent provides to me, I can then start scoring these specific behaviors. And then I'm going to use good Vineland interviewing by using open-ended questions to get at those more specific behaviors. So how about having a best friend? And how about maintaining friendships over time, say longer than a year? And if you wanted to look at an example open-ended question, you can click this probe and it will bring up a sample question for you. And you can also do the same by clicking on scoring criteria. And then you can score. And then if the parent, many times we as parents don't see or observe every behavior that our child does, you can ask the parent to give their best estimate. We just don't want too many estimated items to render the assessment invalid. So you can move forward and backward by screens within a subdomain, and you can type all of your observations and comments in there. So it's quite easy. When you're conducting a semi-structured interview, please use open-ended questioning. Once you ask a yes or no question, you are providing a leading question. So you're leading the informant to give an answer that they might not necessarily have given. So as much as you can, just get into the mindset of asking those how about, what about, tell me about questions that offer just open-ended responses. So this is a typical profile that you would expect to see in a child on the autism spectrum that has intact cognition. This particular individual has above average IQ of 119. You can see based on their standard scores, domain standard scores have an average of 100. So you can see they are much lower, especially in socialization here with a 68. When you see this discrepancy between scores, you render the adaptive behavior composite uninterpretable, which is more often than not in my experience. And then within domains, you can also see variability. It's very common, especially in these high IQ, high language individuals, to see deficits in functional, receptive, and expressive language, but intact, if not excelling, written communication. And that's because autism loves numbers and letters, reading and writing, because those things never change. They're a constant. So this will be a personal strength that inflates the overall communication score. Daily living skills really depends on the parent and how much or how little they demand of their child. In socialization, this will be the lowest domain often, especially in older individuals, with interpersonal relationships and coping skills being very low. So these are profiles that you'd want to look for when considering a diagnosis of autism. And then what we do is we take that information and we use it to inform treatment and intervention. So the Vineland 3 has an intervention guidance that you can have printed out from Q Global that will give you all of the items by subdomain, starting with the subdomain that had the lowest score, that shows you for each item what the score was, and then how they cluster by topic area. So in this particular instance of written communication, this particular individual had lots of zeros and ones in the content areas of B and C. So now I can just look within that subdomain that B is developing reading skills and C is developing writing skills. So that's done my work for me. I can just make a recommendation for developing reading and writing skills based on the intervention guidance I received from the Vineland 3. And so use this to your advantage, especially when writing specific recommendations for adaptive behaviors that you know are high up on the hierarchy, whether they're safety concerns, their toileting skills, their whatever it is that that individual needs to be self-sufficient at whatever age and level they are. So now if we think back to this spectrum where before I was describing it based on level of cognition, now let's think of it in levels of adaptive functioning. So remember here on the left side where we had the low cognition and I was saying we're very good at making these recommendations to dress, bathe, toilet, feed, etc. We need to be just as cognizant of writing these recommendations for functional independence on the high cognition end. So things like social awareness and emotional awareness, personal care, and that still could be something basic like grooming and hygiene, but it could be also about menstruation and puberty, and it could be about, how do you present yourself during an interview for a job, and then community navigation and financial management, among others. Because there's so much current literature showing and emphasizing these deficits in adaptive behavior and autism, more and more treatment studies are looking at the impact of adaptive behavior on outcome. And we're seeing now more and more frequently that if you target adaptive skills specifically in a treatment program, big surprise, you're going to see improvements in adaptive behavior quite quickly because it's modifiable. And so whether we're looking at drug therapies, behavioral interventions, manualized interventions, it's important to be fostering adaptive behavior and measuring it as an outcome. So this just, and thinking about things, why is adaptive behavior so important? Because it is self-sufficiency. So from upon diagnosis, be reiterating this to families, to treatment providers and school systems to encourage individuals to be as self-sufficient as possible. That's not going to happen overnight, so we want to be on top of this throughout development so that by the time the individual is transitioning into adulthood, they know how to advocate for themselves so they're not prompt dependent and they're not reliant on having another person available to them at all times. You want to teach that individual to say, I have a disability, these are the supports I need, these are the accommodations I need, and these are the modifications that I need you to make because of my disability. So one of the recommendations that I often provide is this 411 on disability, because it provides like a workbook type thing for an individual to really go through all of their skills so that they can enhance their awareness of what actually is hard for me. What am I not doing so independently? And that's keyed so nicely into adaptive behavior. So with that, I just want to finish by saying a few things about our new reality here in COVID times. By now, it's just our new quote unquote normal, right? That we are just living with a new way of conducting assessments. And at this point, a year ago, I'd be talking about solely doing remote assessments, but now we've moved into a hybrid. And I myself, I'm in private practice. I have my own clinic. I don't have to share space with anybody, and I'm fully vaccinated. So I have started seeing individuals in my clinic in person. However, I will still wear PPE. I still wear a face mask, and I still require that people coming into my clinic wear a face mask. If I'm doing a direct assessment of social communication functioning, especially with a toddler or a very young child, I don't require them to wear the mask if their family is comfortable with them without it. But I also have found that the hybrid of doing some components of an assessment remotely are very beneficial, not just to me, but to the families, because they don't have to travel. We save all of that time. It's so much more convenient to do a 2-hour developmental history with a family in the comfort of their own home, where I just have to turn on a video. So with that, we do have to understand that standardized assessments, whether it's adaptive behavior, cognition, speech and language, you name it, they were not standardized via telehealth and or with examiners, examinees wearing PPE like facial masks. So we need to use our clinical judgment to say whether or not we feel that breaching this standardization had an impact on results. And the majority of my telehealth assessments and my in-person assessments with PPE, I have not found either the video platform or the wearing of PPE to negatively impact my diagnostic impressions. When I have been very transparent about that and just say, I cannot make a confirmatory diagnosis at this time. I am going to give a provisional diagnosis if I'm even that confident to do so, and then put specifically in the report that a reevaluation is needed when COVID restrictions lift. Because we as clinicians make the diagnosis based on our expertise and our judgment, that's a huge burden on our shoulders. We cannot get it right all the time. We have to give ourselves a break and allow ourselves to say, I don't have it. Let yourself off the hook. That's the take-home message there. But Pearson offers so many options for remote assessment, whether you're talking about IQ measures, and there are IQ measures that you can conduct remotely. There are speech and language measures. There are sensory measures. There are definitely, psychiatric and psychological measures, especially if they're rating scales. They're so easy to administer. And then definitely the Vineland. So even though the Vineland was standardized with in-person interviews, without a doubt, you can conduct a Vineland via video conference. I would not suggest conducting it over the phone, just because I personally like to have that rapport that's established by seeing another person. If you absolutely have to, then it's better than nothing. But and for all of these measures, you can just click on it, and let's just say you click on Vineland 3 here, and you're going to get how to administer it via telepractice. So Pearson has this all for you on their website. And what I do, and sorry to scare you with this picture of myself, but I will do a split screen on my computer. This is just my preference, where I bring up Q Global on one side to do the interview, and I bring up whatever video platform is on the other side, so that I'm looking at the caregiver, not myself. I'm looking at the caregiver while I'm scoring the interview. But another way you could do this is you just have your video platform in front of you and hold the tablet where you're on Q Global, or you could be holding a clipboard and conducting it with the paper version. So very easy to do. People are starting to collect data on all sorts of telehealth assessments, so that then perhaps when we're moving into revisions of these assessments, maybe there will be standardized data of conducting these assessments via telehealth. So with that, I just want to give you a summary that, it's standard practice to include adaptive behavior assessments and a comprehensive diagnostic evaluation for autism. Adaptive behavior is strongly associated with optimal outcomes. So please, please, please be emphasizing the importance of it, even in your smartest, highest cognition, highest language individuals. And we can collect information in many different formats, but the semi-structured interview format is the gold standard. And if you are still form, then know that your clinical judgment is so important in determining the validity of findings. So with that, I want to thank you for your time and attention. I do believe we've left ample time for questions, which I'm happy to take at this time. But with that, wanted to see if Sherry and Aaron have any comments that need to be made. So thank you.
I think this has been great. Would you like me to read the questions out to you that we have that are unanswered, since I've been kind of following along with the questions? Would that work?
Oh, sure. That would be great.
Okay.
I'm trying to figure out on my end how I get back to seeing where those are.
Okay. Well, I'll read them out to you and can repeat them if necessary as well. So can you address children who have oppositional behavior and refuse to perform skills on the adaptive forms, usually typical cognitive and not necessarily autism? This comes up in schools when we are determining disabilities.
Of course. So if you actually, I believe it's stipulated in the manual that a score of 0, there are various different reasons why you could get a score of 0 with adaptive behavior. One is that they don't have the skill yet, so it's not performed. One is they have the skill, but they're not doing it. One is that they're never given an opportunity to do it. So like using a knife, parents will flat out say, well, I've never given my child a knife. Well, that's a 0. It could be a 0 because they're too young and they shouldn't have a knife, but it could be 0 because they're 20 and they should be using a knife, but they're not. So when it comes to oppositional behaviors, if those behaviors are resulting in the individual not independently performing a needed behavior, it's a 0. And so, or if they sometimes do, sometimes don't, it's a 1. And this is why treatment programs, for example, parent training, there's a parent training for autism, problem behaviors in autism called Ruby parent training program. And that was effective in increasing adaptive behavior in as short as 16 weeks. Because of that, because the treatment was addressing the problem behavior. Once you have the problem behaviors decreased, the adaptive skills that were in the repertoire were naturally applied. So I hope that answered that question.
Yeah, that's great. Thank you. What skills are you referring to when you talk about adaptive skills?
So adaptive skills, think of everyday practical skills. So within the area of communication, it would be functional understanding of language and use of language. So it's not just that I have a repertoire of words. So think of your Asperger type individuals on the spectrum. They have a huge, if a speech pathologist assessed their repertoire, they'd be off the charts with a standard score in the superior range. Can't functionally say, hi, mom, I love you. Could you help me, please? And say to their friends, hi, how are you? I know that you love sports. Let's talk about baseball. So they have those words in their repertoire, but they're not applying them for social purposes or communication purposes. The same thing happens with motor skills. So a person can physically do the behaviors to dress themselves, but they don't. So that's an adaptive deficit. So it's just these real life skills, and they can be personal care, domestic care, doing chores. It can be navigating the community. It can be motor. It can be socialization. It can be conceptual.
Great, thank you. Kind of related, when older students with autism spectrum disorder are in a general education setting and the academic demands are rigorous, how do we appropriately address adaptive functioning skills in a public school setting?
That is a great question. And so first and foremost, get out the IDEA Act, the law, because the law stipulates that special education is not just academic. It's for social and _ adaptive purposes. So you need to maybe help the families get an advocate that will emphasize that their child's special ed needs to focus on adaptive skills. You can make the point that academically they're excelling and they're doing fine. But if they have an IEP or a 504 plan because of their eligibility for autism, then they need to have the goals and objectives that meet those needs explicitly documented. And I would be inundating that IEP with goals and objectives for adaptive skills. And these, I'm for error here. So any time that's non-academic, walking between the halls, any breaks, if they're in middle school and they still have outside time, and they have lunch, try to have all the programming during those down times so that they're less structured and more social. That's when I would have a lunch bunch or a buddy or something paired up to work on these skills.
Great. Are there intervention programs for adaptive behavior that you have found to be successful in school-age kids?
Oh, I'm going to show you one that's right here in my office. So the hard thing is there aren't really many manualized programs for adaptive behavior because, like I said, you can commercially buy like toilet training books or, social skills books and things like that to work on individual adaptive skills. But in adaptive behavior programming, it's few and far between. But one of them here is this Functional Independent Skills Handbook. It's an assessment and curriculum by William Killian. I don't know if everyone can see that, if you're looking in my view. So William Killian, it's called FISH, Functional Independence Skills Handbook. And it's published by ProEd. So that's just one of the things. But like I said, I'd be more apt to look at the profile of adaptive weaknesses and then really kind of key into interventions for those weaknesses. So if it is in motor skills, I'm key into occupational therapy, social communication, which is highly likely. I'm going to make specific, like, you need to teach conversational skills. You need to teach awareness of gestures. You need to teach use of gestures. You need to teach the function of eye contact, not just look at me and teach someone to stare at everybody, but why is eye contact meaningful? If you're not looking at someone, they might think you're disinterested in them. So if you're in a job interview and you don't look at the person interviewing you, they might not give you the job. So these are the types of recommendations I tend to make rather than giving a recommended program per se.
Great, thank you. How can we account for difference of cultural expectations that may affect performance on adaptive skills? For example, within some cultures, children are fed by parents at a young age, but in Western culture, children are expected to eat independently at a much younger age.
And that's also a great question. And the thing is, the Vineland was standardized in the United States. We tried to be as culturally sensitive as we could for behaviors. So things like, instead of using specific utensils, you can incorporate chopsticks and other types of utensils, or instead of saying looking someone in the eye, it's using culturally appropriate eye contact or reading in the direction of your language. But because it's the United States, we couldn't modify that for absolutely every cultural difference. When the Vineland is translated in other countries, I believe in some cases they've made those modifications, but then it's up for those countries to redo the standardization in their own country. I think what it comes down to is and I've had families say that to me, it's just not a priority for my kids to clear the table after dinner. I'd rather them go do their homework and get it done. Like, that's the priority in our family. So I'm not going to make a big stink about their personal daily living skills in my recommendations, but I am going to make it for their safety concerns, the fact that they're socially gullible and that they are easily manipulated by others, right? So if a parent says, well, you know, I do this for my kid, and they're a helicopter parent and overprotective, then I will actually speak up and say, you know, this, regardless of a cultural issue, the individual themselves is at risk because they're approaching adulthood and they need to be aware of when they're being manipulated, especially females, right? But even males. So that's when we just have to be considerate of making blanket decisions based on culture.
Great, thank you. What age range do you use for that 411 book, and do you give it to parents?
So I have given that starting in adolescence and maybe even early adolescence. I do, because usually then I'm giving it to the parents. It's in the report that the parents get to use with their child. But I also have provided it to adults. I see many adults. I'm giving the diagnosis for the first time, and I provide the same recommendation. So I would say both. It's really important that adults are preparing for this transition into independent adulthood far before adulthood, right? Not the senior year of high school when you're trying to then cram it all in. That would be great. So be part of this process.
Thank you. When an adult has optimal outcomes and symptomology does not impress as meeting diagnostic criteria, do you continue the diagnosis of ASD?
Oh, that's a challenging question. When that has happened at school age, I do retain it. And this is why. More often than not, when I have seen a diagnosis removed for that reason, I've gotten a panicked call from the parent within 6 months to a year saying, help, what did we do? We took away all the services that made the individual look so well. And without those supports, they crashed and burned. If it's an adult that by that point, they have learned effective compensatory strategies to be functioning well in life, or person, then by all means, I would say there's no reason to carry the label unless you need it to continue those supports.
Related question, where can people find that book?
Which book?
The 411 book.
Oh, let me see. This www.ncwd-youth.info.
Great, thank you. How do you accurately assess someone with a severe intellectual disability for an educational autism classification?
Okay, so let me differentiate something here. I'm a private practitioner in the community. So when I give a diagnosis of autism, it's a medical diagnosis of autism. That's not an eligibility diagnosis for school systems. It happens, and I'm in Georgia. This differs state to state, from school to school. So if I provide, or I don't provide, if the family provides my medical report to the school, they can use that and say that meets their eligibility criteria for autism, but they might not. In some cases, they redo the entire evaluation themselves. And you're hoping when that happens that the school system has an autism component of their assessment. Many schools don't, and that's why they refer out. So with that, I would hope that even in the school system, a comprehensive evaluation is a comprehensive evaluation, that it's going to include, if you need to determine ID, it's going to have an IQ measure and an adaptive measure, and then it's going to have the autism getting to the comprehensive standard anyway.
Another question came in about how to answer Vineland questions when a child uses assistive technology to communicate.
So this is also stipulated in the manual that for the expressive and receptive communication domains, or even in socialization, if it has to do with conversation, you should give full credit for any augmentative or assistive technology, including sign language, if the person is using it independently. If you have to prompt the individual to use their PECS program, for example, to point to a picture, that prompt renders it a 0. But if the child is hungry and they spontaneously take their device and press even one button that says cookie, credit for making the request and using communication. So without a doubt, give full credit in that regard. I think where it's challenging for us with the Vineland is the Vineland was not developed for motor disabilities as such. So when it comes to physical inabilities, so walking up and down stairs, for example, there isn't an alternative for giving that. So individuals will come out with a low motor domain, but it's optional anyway and not included in the overall composite.
Great, thank you. When would you recommend using the domain rating scales, and what communication would you have with the rater prior to them completing the form?
So in the domain, remember the domain versions can be as an interview form. So they should really only be used in determining eligibility for ID. That's how it was developed. It was a quick and easy way to just determine eligibility. It was not determined to inform treatment and intervention whatsoever. So if you are using your results to inform a treatment program, do not use the domain form. That would be my advice. But if you're just like, I just need to document, or this child, it's in his like 3rd triennial, so we have ad nauseum assessed cognition and everything, and adaptive behavior in the past. We know this individual has ID, we just have to do the triennial, and something like that, I would say it's very applicable. And just know that the domain version can inflate scores in some areas up to 5 points. So if you compared to someone who's on the borderline to mild, and you need that to determine your eligibility, it might not be the best thing to use. Want to be more sensitive with the comprehensive.
Well, thank you so much. I realize we've gone over our time just a little bit, but thank you so much for your time today. Thank you for all this information, and thanks to everyone that has joined us for this presentation and was listening in.
Yes, thank you, everyone.
Thank you. Bye-bye.